Welcome to and welcome to our early morning webinar. I'm going to wait just one more minute to get people on. I know we usually do these over lunch, but our rig people felt like they wanted something early in the morning before they start their day. So I am very excited to have all of you present. I'll start in 1 minute.
I see some rebels here.
Perfect. So I'm going to go ahead. My name's Mary Hook, and I work for Advocate Health in the Midwest area and in the Southeast. I am the current chair for the Midwest Nursing Research Society RIG for acute and critical care across the lifespan. We have been very engaged with working with Dr. Martha Curley this year on the call to action and the blueprint for change for acute and critical care nursing. So we thought it would be awesome to have Dr. Curley and her counterpart, Dr. Laura Calvis, be able to present the latest and greatest info on this important work. So I'm going to go ahead and turn our program over to our speakers, and we will be able to kind of hear what their content, and then there's going to be an opening for all of us to participate. So again, thank you so much for joining on this. And again, this is recorded. It will be available for MNRS members after the event, so you can tell your friends. So go ahead, Dr. Curley.
So thank you, Mary. And thank you, Barbara, for the invitation to come share in this work. It's really been a labor of love by many people. And Laura Beth and I are really excited to be able to share with you really where this work is. It's a call to action, blueprint for change in acute and critical care nursing. My name is Martha Curley. I hold the Colquitt Chair in Pediatric Nursing Science at Children's Hospital of Philadelphia. I'm a professor at the University of Pennsylvania. Laura Beth?
Hi, everyone. I'm Laura Beth Calvis. I'm a nurse scientist at Nationwide Children's Hospital in Columbus, Ohio.
Yeah, so Laura Beth was my doctoral student when all of this was happening. And so a lot of the legwork went on to Dr. Calvis, and so we appreciate her. And we also appreciate everyone who has been involved with this work. As I said, it was truly a labor of love, and it continues to be a labor of love. All the work that we'll be sharing today is on a volunteer basis. And what we're going to do today, if you can go to the objectives, Laura Beth, what we're going to do today is talk to you about the key components of this call to action. And we believe this call to action, the work is focused around fully recognizing nurses' unique contribution to patient and family outcomes. We'll talk about the strengths and limitations of current measurement strategies for acute and critical care nursing. And then at the end, we'll talk about opportunities that you can engage in to help support this work.
Yeah, and we did want to just say a thank you to Drs. Mary Hook and Barb King for focusing the work of the acute and critical care MNRS RIG on the Blueprint for Change this year. It's been a very exciting time working together to kind of get the word out there to our members. So thanks.
All right, so to give you the background here, this work started at the tail end of the pandemic. And although most of us have PTSD living through the pandemic, call back to really what was going on in nursing during the pandemic. And this picture just so excruciatingly portrays the pain that we all went through during the pandemic. Acute and critical care nurses really, we're the heroes here. And we were recognized as heroes during the pandemic because as everyone sequestered into their homes, acute and critical care nurses went to work and they took care of America and they took care of all the patients across the world who were living through this deadly disease until we had a solution. And so when you think about the pandemic, just arrow down, Laura Beth, it will be like thinking about the pandemic, pre-pandemic, and then post-pandemic. So there was life before and there was life, after the pandemic. But the acute and critical care expert panel of the Academy were meeting through the pandemic, and we really wanted to think how we can really illuminate a path forward. And we really cared about, and this is really from Patricia Benner, I remember her talking about nurses' enchantment with the practice of nursing. We all enter into nursing because we're enchanted with the practice of helping people, of the humanistic pieces of what we do every single day when we take care of patients and families. And post-pandemic, the expert panel really wanted to think about how we could help re-engage and reimagine what we could do to move the practice forward. So all of us, how could we engage in revolutionary thinking about nursing? And during our conversations at the expert panel, we believed that in order to do this, we needed a clear vision of what nurses can do, exactly what do nurses do. We needed to strengthen our evidence base so that nurses can truly own their practice and lead practice changes. And we had to make visible through data nursing practice that contributes to optimal patient and family outcomes. So we were very much in agreement that we needed to lead in some way. So our work on the blueprint, started. The authors on the right were what we consider to be the Fab 15, fabulous 15 authors, and Laura Beth highlighted here members who come from the Midwest Nurses Association. But really what this blueprint does was, 5 major things. We wanted to highlight the outcomes of stellar nursing practice, making them visible to all, making them visible in articulating them from patients and families' perspective. We do lots of measurement in nursing, but it's really about who nurses are and what, in describing nursing and the practice environment. But we really wanted to focus on what do nurses do to influence outcome. We called for a major change in how nursing is measured in hospitals. In order to do that, we had to articulate domains of practice that we felt were the core elements of what nurses do, so that we could better support their capacity to provide optimal care. We wanted to propose precision-based outcomes that call attention to the presence of nursing, not the absence of nursing. We'll talk more about that. And then really the call for action was really a call for partners in this process. The Fab 15 engaged in the work and wrote the paper, but now we're inviting everyone to essentially, pick up this call to action. So in talking about, the blueprint, there are 3 perspectives that are presented in this paper. And if you go to the chat, you'll see the paper itself. So if you haven't seen this paper, thinking about pulling it. But when I think about the paper, really, to quote Stephen Covey, it's like we began with the end in mind. We knew we needed better outcomes, but in order to really articulate those outcomes that really talk to the beauty of what nurses do that really helps them to take care of patients and families and energizes them in the process, we really had to have a clear understanding of what nurses do. We didn't want nurses set up to fail, saying, okay, we expect these outcomes based on the work. We also paid attention to key hospital environmental assumptions. Although the focus of this work is not on the hospital environment, that's not part of it. It's really about what nurses do and what outcomes that we can expect. And when we had the months of conversation in this process, we would go back and forth. We would flip into, so what do nurses do? And what do we need to have within the care environment to support the work of nurses? And then how can we think better about patient outcomes? So it wasn't, a linear process, although it's presented. It's really a flip process on what did we want to create and what needed to happen to help create that. So what do nurses do? We settled on 9 practice domains, basing the work, on the scope of standards of practice, and also leaning heavily into Benner, Care, and standards, clinical wisdom, and interventions in acute and critical care nursing. The qualitative, the qualitative analysis of the practice of acute and critical care nursing. So the work is based upon, these 2 pieces. Number 1, nurses create safe healing environments. Without doubt, nurses really are the people who, create a safe healing environment. This leans into the work of Florence Nightingale, long tradition in nursing. You put patients in hospitals. Nurses own the environment that keeps patients safe and facilitates their healing. So it's not just about patient safety, but it's what is it within the care environment that we modulate so that patients could be advantaged to heal. The second one is building caring relationships with patients and families. I mean, from the get-go, we initiate our relationships with patients and families. We find out who they are as people, what drives them, what do they want from a cultural perspective, from a developmental perspective. It really is who are they as individuals so that we care for them as individuals, context within patients, contexting these patients within families. The third is assessing and manage patient symptoms right from the get-go. It's like, what's the patient's chief complaint? How are we assessing that? How are we delivering upon managing patient symptoms? The fourth is we provide all of their physical, therapeutic, preventative, and end-of-life care. We provide fundamentally their care. We do for them until they can do for themselves. This goes back to Henderson's perspective of we stand beside, we do for them and teach them how to do, how to care for themselves. The fifth is we always are on guard. We provide surveillance from the get-go. We know what patient populations are at risk for, and we're ready to intervene. So this gets into, again, the individuation of patients coming in. Who are they as people? What are their risks? And how do we take care of them? We teach patients from the get-go what they need to know in order to actively participate in their own care and decision-making and manage their own care after discharge. And this is, it's like nurses are teaching constantly. We constantly bring them in. We help patients and families be present. We help them, be aware of a trajectory of illness, what to expect every day, what to expect from the care team, who the care team is. So we're teaching patients and families what they need to know in order to be successful. We collaborate and coordinate care within the interprofessional team. We don't do this by ourselves, absolutely, but time has come where we need to be able to articulate what we do and how we contribute to outcomes. Absolutely, within the interprofessional team, we partner with OT, PT, speech, and pediatrics, child life within multiple services, but we are the people who are coordinating care. We speak up when there's a deficit. We speak up and say, maybe we should bring another subspecialty in. And we contribute our nursing knowledge within the interprofessional team. We own what we do, we lead what we do, and we contribute that within the interprofessional team. We advocate because of our knowledge of patient and family from the get-go, because we've built these caring relationships with patients and families. We advocate for them, making sure that their preferences are met. And then lastly, we navigate transitions in and across healthcare systems. So we help them be successful to move in across hospital systems, being the conduit that facilitates this. So this is the work of nursing, all right? This is what we do. And I can honestly say, if you look at this, not all of this is acknowledged and measured within acute and critical care practice. This was a illustration that we published in one of our dissemination projects that looks at what nurses do are based upon what patients and families need. So we make sure that we give them what they need within the interprofessional team, within the practice environment. And if you look at these 9 domains, caring and healing environments holds the whole thing up. And then within the care environment, we build relationships, manage symptoms, administer care, provide surveillance, and educate patient and family. Within the interprofessional team, we collaborate and advocate, and then moving out of the practice environment, we navigate transitions. So this is the work of nursing. This work within the practice environment, the assumptions of care within the practice environment are also articulated in the paper. You know, the core elements include that nurses are adequately prepared to practice, that nurses have the expertise aligned with the patients that they're caring for, that we can fully practice unrestrained from local policies that really restrain the work of nursing, and that we could practice to the highest level of expertise that we can, and that we work in systems that are supportive, you know, of this. So we've talked about what nurses do. We've talked about the practice environment. So what we then did is try to search for every single outcome that had been articulated, given the regulatory bodies and anyone who credentials us. So we did major reviews of HCAP, CMS, NDNQI, Joint Commission, you know, ANCC. We looked at best hospital reports, promise measures, and then anybody who provided any type of guidelines. And from there, we started mapping out the outcomes according to the domains. And so, you know, table 4, I believe, in our paper talks about what was currently measured within the 9 domains and what was present and examples of future measurements. So on the next 3 slides, we talk about how is safe healing environments measured, okay? How was caring relationships measured? Most of them were through HCAP survey questions. Symptom management was there, but not, you know, not in a perspective that probably should be there. You know, the 4th is administering care. All of the care that we provide really didn't have too much current measurement. And then all the therapeutic complication and harm prevention, you know, we are, Laura Beth will talk more about this, you know, a lot of it has to do with the absence of nursing, you know, catheter-related infections, clot, eclampsia, you know, line infections. So it's really about the absence. Unbelievably, end-of-life care had no outcome metrics at all. And those of us who work in acute and critical care know that that's where some of the best of nursing happens at the end of life. Providing surveillance, no measurement at all, current measurement. We have some suggestions. Teaching families, you know, maybe some HCAP questions and some custom questions, but really not there either. And then the very last one, collaborating with custom questions, advocating one HCAP question, navigating transition, one HCAP question. So when we reviewed all of this, it was really disheartening to really acknowledge, given our review of the existing metrics, little of really what nurses do that makes a difference for patients and families were being measured. So our work continues.
Yeah, so around the same time that this paper is being put together, Martha and I started working with Natalie McAvoy, who's was a Fulbright scholar, to Penn, looking at the currently available nurse-sensitive outcomes in the literature. And so we started thinking about what are we looking for, and we knew that these outcomes, patient falls, pressure injuries, and hospital-acquired infections, are the most commonly measured nurse sensitive outcomes. They're make up the bulk of what Magnet's interested in. CMS has them listed as well, all sorts of organizations. But when we think about these three outcomes, as Martha was just saying, they're really harm metrics, and they really reflect not the presence of nursing care, but the absence of it. And so when we went into this review, we were thinking, what do nurses do is more important than what nurses don't do. And thinking about those three outcomes that are the most commonly measured, they're hitting the first domain of nursing, creating safe healing environments, and they're kind of hitting this some of the fourth domain, that preventative care. But look at all of these other domains that those commonly measured nurse sensitive outcomes are not addressing. So we performed a systematic review of the literature looking for nurse sensitive outcomes that were not those three. What else is out there? What else are we using to measure our work? We found a total of 55 nurse sensitive outcomes. Only about 70% of those had an operational definition, so that people were telling us how they are actually measuring that outcome. And then only 15% had a conceptual definition. So kind of really missing that theory to measurement piece in this work. And looking at these outcomes, the most commonly identified ones were patient and family satisfaction, unplanned extubation, failure to rescue or mortality, functional status, and peripheral IV infiltration. And then in addition to those, there were some clusters of kind of related outcomes, patient complications, including those that are related to the ventilator, those that are related to surgery, symptom-related outcomes, and then nutrition and feeding related outcomes. But really looking at this, we're still missing so much of those 9 domains. And so I went ahead and I mapped the identified outcomes from our literature review to the 9 domains. I was seeing for each cluster of nurse sensitive outcomes, what domains were they mapping to? And then I tallied up the number of different matches from the outcomes to the domains. And what I found was that there are still so many of these domains that are not being addressed by the currently available nurse sensitive outcomes. So building caring relationships with patients and families, assessing and managing patient symptoms, teaching patients and families, advocating for them, and then navigating their transitions were all very poorly presented and or represented, in the literature. And so the conclusion of that work was what is needed: a common set of nurse sensitive outcomes for acute and critical care settings across the lifespan. A common set of outcomes would allow for consistency across symptoms and studies, which would be extremely beneficial. But we also believe that this common set of outcomes need to have the ability to personalize to specific populations and care settings. So an example would be a nurse-sensitive outcome of symptom management, with the symptoms that you can select would be based on your population or care setting. And so putting that power within the nurses who work in that setting to know their patient population and know which one of those symptoms best fit the patients they work with. So that might mean pain being important in the surgical setting, nausea being important in the oncology setting, et cetera. And then also thinking about how we can flip the narrative on these harm-related metrics, because so much of what we see in the literature is related to patient harm. So just examples for those 3 common ones that we all know very well, of thinking about for patient falls, instead of how many patients fall, thinking about how many patients are at a true high risk for falls, a true high risk, not that we're just slapping yellow socks on everybody who comes into the hospital, but who are at high risk for falls who do not fall, because that represents nurses doing that care to provide a safe healing environment. Same for pressure injuries, patients who are at high risk who maintain their skin integrity, and then percentages of patients who have central lines or urinary catheters who do not go on to develop CODIs, CLAPSIs, et cetera. And so again, just reiterating that there are many unit level and system level outcomes that are nurse centric and important. So nurse satisfaction, making sure work environments are healthy and supportive of nursing practice. But what we're focused on here in this work is patient sensitive outcomes, not these nurse centric outcomes. And so moving forward, now that we're somewhat out of the pandemic and focusing our practice on building and testing new models of care, we need to center our practice and our outcomes measurement on the unique needs of varying patient and family populations. So again, we have a common set of nurse-sensitive outcomes with the ability to personalize for the patients that we take care of. Another example here, going from generic to specific outcomes, there could be a composite measure on comfort. And there could be different components within that composite measure based on the patient population. So adequate pain management Perhaps that needs to be measured for all patients, but Martha also brings up this really great point that if we're measuring pain on everyone, even those who have no indication that pain is an issue, is that measurement of pain meaningful? If you measure it on everyone, what is it that you're getting at that's meaningful? So thinking about who's at high risk for pain, are we making sure that their pain is adequately measured and adequately managed? For intubated patients, thinking about how we measure sedation for comfort, delirium for patients who are in the pediatric, well, here we have pediatric because we're pediatric nurses, but any critical care patients. Although also, thinking about this can happen on the floor as well. Withdrawal from sedation, making sure that patients who have been exposed to sedation are having their withdrawal symptoms adequately managed. So again, you can personalize all of these based on your patient population. And so in the end, the kind of conclusion of our blueprint was putting all of this together. So pulling in kind of the figure that was shown earlier, matching what acute and critical care nurses do, the 9 domains, with what patients and families need, which is situated within the practice environment and is also working within an interprofessional team. All of this contributes to patient outcomes as well as system outcomes. And the way that we look at these outcomes is through this new core set of nursing metrics, which represent the full spectrum of care that are patient-centered and population-specific. And thinking about who we need to partner with in this process of measure development. And we'll talk later about who we've been speaking with and kind of building partnerships with, but we need the cooperation of professional organizations, healthcare centers of excellence, industry partners, consumers. Those are who are going to help us build these measures. But then you have to think about the policies that will encourage systems to use those measures to measure their outcomes. You need policy. So that's where you would need to bring in regulators, accreditors, payers, certifying bodies, and consumer groups to help support the incorporation of those measures into routine policy in healthcare.
So why don't we just hold there? So really, we really wanted to be able to call attention to the work of nursing in acute and critical care settings. We understand that there's a hell of a lot of nursing going on everywhere, but we had to narrow the beginning of our work on where most of the nurses in America practice, and that's, in hospitals and critical care areas. After that, it can go further, but focusing on, where the heroes were functioning during the pandemic and acknowledging that we really weren't measured in their work, okay? And so the disillusion and, tell me about what I am doing right and what I can be doing would be the strength of this work going forward. I see some, what I call rebels on the call. Anybody would like to add anything to how we started developing this work? Please speak up. Just come off mute and raise your hand, and I'll look around and see if there's anyone here who wants to say something. Chris, you came off mute. Did you want to say something?
Yes, I did come off mute. Hi, I'm Chris Latham. I'm from California and part of this Rebel with a Cause group. And I think initially, I think you hit the nail on the head, Martha, that, we really were during pandemic, post-pandemic, stopped hearing about the heroes, the work that nurses were doing, and we really just wanted to call attention to it. It really snowballed, as you can see, into a very comprehensive approach to not only looking at what was there and what wasn't there, but how to move forward.
Mm-hmm.
And I think that's going to be the next portion of this. And it's really been an incredible journey that we need additional support for, if any of you are interested, to really bring this home. So that, yes, we have articles out there. In fact, there's articles in most of the specialty journals as well now about this blueprint. But we also want to actually, do the work of getting these measures and bring them into practice so that nurses get the credit that they need. I'm from the academic setting primarily, although I am a critical care clinical nurse specialist, and I am bringing this into the academic realm So there's currently hospital representation nationally, and we're doing the study. It will be presented at the Transform Conference for the American Association of Colleges of Nursing this December. And it's very exciting work. We have students in experimental and control groups, as I said, with national representation in university settings. So,
And so, Chris, it's really exciting because, when we started, it was just the 16 people sitting in a room debating for like a year about what this was looking at. And we had expertise in the panel, to really bring forward. And Chris's work in academia and in the essentials document, linking this work with other existing work is critically important. One of the reasons why we came to this group is that it's a research society. And so we want PhD prepared nurses, doctorate prepared nurses to find themselves within this work and move this forward. And even, for example, when I reflect upon Laura Beth's review of the literature, in clinical trials, in studies, we do really a lot of work on symptom management, but they sit within, isolated studies. They're not mainstream. We need to take the measurement of what we do within our trials out of that and move it forward. But Chris's work on, the essentials and leading that work is just, so phenomenal. So, thank you, Chris. It's really awesome. Other people, Lauren, you're off mute.
Yeah, thanks. Good morning, everyone. Lauren Source from Lurie Children's in Chicago. When Martha and I first started talking about this, however long ago it was, I feel like it was before the pandemic, but maybe not. And this idea that nursing is measured in the absence of nursing. That statement, in my opinion, should set everyone's hair on fire. There really isn't many things in the world that measure the absence of the role or the absence of positive outcomes. So if you think even outside of healthcare in the business world, it's okay, how much money did you bring in? How many accounts do you have? How many lawsuits did you settle in the positive? And so when we think about nursing being the most trusted profession for over 4 decades, it's a little unbelievable to think that we don't really truly measure what nurses do. And so this idea of transitioning healthcare really into positive measurement for the outcomes that nurses really own and or contribute to for our patients and families is fundamentally going to change not only how nurses practice, but to Chris's point, how nurses are educated and how we can continue to make a difference. And so it's going to be through research that we more clearly define these outcomes and are able to then measure them more precisely. Thank you, Lauren.
I think we did, it's been in the background for a very long period of time. It's been there, but, we really had to reach agreement on what was the work in a generic way. And Laura Beth talked a little bit about the need for generic metrics. But then the beauty of nursing comes from really population-specific metrics. So leading this work forward, we absolutely, have pushed hard on making sure that we are making some progress. So Laura Beth, can you go to the next slide? Just we'll have more time for questions at the end, but let's just talk about what we've done since we published the paper. And absolutely, after we finished, this paper was in the process for like 1.5 years, almost 2 years. And then when we finished it, we were like, we just don't want to write a paper in Nursing Outlook and have it sit on the shelf. So we started dissemination work. And Laura Beth, thank you for putting together the bibliography. We've got over 15 other publications on this work. Chris talked about it because each of us went back to our individual societies, our subspecialty journals, And we all wrote op-eds, editorials to bring this work forward. So, there is a reference list that talks about our dissemination work. And the Fab 15 authors have now morphed into Rebels with a Cause. And it was interesting because I talked to Rosemary Parsley and I said, we were at the academy and, I talked to Rosemary because some of her work is kind of like enmeshed into this as well. And she's the one that called us, well, Martha, you're like rebels right now. You're just, trying to shake it up, calling for action, want something to change. And I said, absolutely. So we morphed from like the Fab 15 to the Rebels with a Cause. So anyone who's interested in this work, you're welcome to join us. We'll put you on the distribution list. You kind of come in and you go out as you can. But what we want to be able to do here is to create a palette of rigorously developed patient and family core outcome measures, recognizing there's some balancing metrics as well, but each linked to what nurses do, the 9 domains of practice. We want these measures matched to the needs of our patients that we serve, and we want them incorporated into regulatory payment, accreditation, and credentialing benchmarks. So we just we want them created, we want to match them to what nurses' work is, and then get them out. So we've worked hard on dissemination. We continue to do our crosswalks. Crosswalking, like I showed you on figure table 4 in the paper. We're going to look at HCAHPS and try to reframe them from a nursing perspective. We're working with CMS, and CMS was really interesting in that there's there used to be over 200 nurses working at CMS, and we're still working with them because the nurses working with CMS absolutely agree with us that we're not measuring nursing, and they would welcome an opportunity for a measure to move it through the Batil system now. So that's kind of like where we are, but we've moved on to some validation work. So the concept mapping that we are involved in now, the Rebels have aligned with the 9 domains. Highlighted here are Midwest Rebels highlighted. We have a lead within each of the domains. We have other people who have joined the group. And the goal here is to do some operational definitions work that would lead to better measurement of that domain. So if you're interested in any of these 9, please contact me, the leads of the concept mapping, and join the group. And we're doing a straightforward Walker and Avant, conceptual development here. So it will lead measurement. We also are validating the blueprint from nurses' perspective. So currently, and if you're interested, the link to the survey is there. Scan it on your phone. And what we're asking acute and critical care nurses to do is to let us know whether or not these domains fall within their practice, how often they practice these domains, and how important these domains are to their patient outcomes. And currently, we've got over 700 responses. So we're going to keep this survey open till the new year. We want to hear from everyone. We specifically want to hear now from nurses of color because right now we have a whole bunch of surveys completed by what predominantly is, nursing in the United States, but we want to hear from nurses who are atypical of what typically occurs in surveys. So we want to hear from everyone so that we can see various people's perspectives. So please scan that and complete the survey. We'll keep it open indefinitely. And really, we want to know if there's anything that we're missing. And I can say after looking at the 700 responses, what appears to be missing could absolutely be fit in the current domain. So I think we're good there. So we've got good validity from nurses' perspective. We're moving on to patient-centered validity. So with the generosity of Bonnie Barnes and Deb Zimmerman, we're probing through all the DAISY nominations. And so it dawned on us that we have, thousands and thousands of nominations of what patients and families believe to be stellar nursing care. And so what we're going to do with the leadership of Devin Carr, who's the CNO at Maine Medical, who's going to be inducted into the academy in 2 weeks. Our goal is to validate the 9 domains from patients and families' perspective. And so we're going to probe the 9 domains to see, or probe, 80,000 DAISY nominations for the 9 domains. And so we've got this qualitative process now looking at, what is embedded within these nominations. Can they be aligned to the 9 domains? Developing a lexicon of language that patients and families use that describe the 9 domains and maybe other domains that are important to patients and families, and then using natural language processing, validate that within the 80,000 patient and family nominations. And so we're using machine learning, natural language processing to validate this from a patient and family perspective, using their own words. Okay, once we have this done, then we can go to HCAP and say, okay, HCAPs were billed by non-nurses without the patient and family's experience. So we're going to see whether or not we can change those questions that talk about whether or not nurses answer the call light on time to more substantive questions that really align with the work of nursing. So this is pretty exciting, using contemporary methods to prose existing data. And really thank you to Bonnie Barnes for allowing us to do that. We have 2 other projects going on as well. Meg McCabe and her nursing research team at Children's Hospital of Philadelphia are probing nurses' notes, existing documentation, to see whether or not the 9 domains come alive and looking for outcomes associated with that. But it's kind of interesting when we thought about how we can really get the evidence to support the 9 domains, thus the outcomes that we want to go after. A lot of organizations force nursing documentation in fields that may not be relevant for the practice of nursing to cover, what regulatory standards are or local interpretation of regulatory standards of what gets documented. But it's really looking at pre-filtered, structured data. And so we want to back that up a little bit and almost do what, for example, Kendrick Cato did with the Concern study, looking at non-force fields nursing documentation. Where were nurses concerned about patients? And I think his study in and by itself can get us to the surveillance function of nursing and validate that. But another exciting project that's going to be led by Anna Schoenbaum and Kendrick is to probe the nursing, Project Nursing ambient listening that Microsoft is currently leading. So nurses go in and they interact with patients and families, and then currently some of that data is forced into existing documentation. But what we want to do is just look at the interaction itself before it's forced into documentation, and then just see how nursing is practiced and what's the interaction between patients and family alike. And it was so exciting when we met with Microsoft because these engineers completely got what we were trying to do. Because in listening to the interactions between patients and families, they themselves, who have nothing to do with nursing, could say, gee, these 9 domains really, do come alive in the data that we have. And they give examples of, snippets of listening where they had a nurse say, hey, Joe, how was your night last night? We tried to get you to sleep X, Y, and Z, and did that work? And how was it? And so it's really, but that interaction never gets captured in nursing documentation. All right. So we're going to just be a fly on the wall and then pull data in and try to filter it into the 9 domains and look for opportunities to measure. There are 9 hospitals who are currently participating in the ambient listening project. And if you happen to be one of those hospitals and would like to participate in our project, please let us know. And then we continue, through this work, building coalitions with others. We've had meetings with electronic health record vendors to help them see that, we don't need, tools to help us identify what nurses don't do. For example, what nurses don't document, but we need tools to allow like freeform so that we can allow nurses to communicate freely what they do for individual patients and families. Chris talked about some of the AACN East work. We still want to circle back with AONL, the American Hospital Association, when we have more of our validity data, completed. But absolutely, what we're trying to do here is really, highlight the outcomes that are important to patients and families, and really make, can you go to the next slide, Laura Beth? Really want to make visible to all what the work looks like. Okay, so we want to change the paradigm here dramatically. And definitely, I think, together, working together, we'll be able to do that. So thoughts on our current projects. Any feedback from anyone on what we are doing, or anybody have any clarifying questions about what we are doing? What do you think of the DAISY project? Mary, you're on my screen, so I'll ask you what you think. And you're off mute.
I'm very excited about this work. And again, I think that's been something that we picked up at MNRS, and we're very excited to have this because we have a rig that's dedicated to this, and you've given us a new launching pad. I do have a question for you. And again, it goes back to, all the really cool things that you're doing. And I just think you're so on target. One of the things that we've been talking about in our organization is shifting from shared governance to professional governance, and that whole idea of professional identity. And I know you are, this work is really very much at the ground level that talks about what nurses do, but it's almost like we need to be able to also speak at that higher level about so that we can articulate that professional identity as well. So that might be a little bit more conceptual, but when we talk about shared governance, it's often about that, committee structures and those kinds of things. And what it really should be is about what we do at the bedside and the decisions that we make, and following best practices, and really being the voice for the patient in places that they don't have one. And again, I just think that might be another thing to kind of link with, because again, it's really based on having a real professional identity that we, what we own, if you will, the things that you talked about.
So Mary, it's really interesting because, in my day job, we are spending a lot of time talking about professional identity. But if you think about current professional identity, when you measure something, you call attention to it. Okay. Mm-hmm. So if the measurement of how you describe what nurses are doing in your organization only has to do with, whoops, another pressure ulcer, ups, another, device-related injury, oh, patient falls, et cetera, et cetera. It's like, yeah, we do some of that, but we don't ever talk about the relationship building, the advocacy. I mean, we surveil patients because we know them as individuals. So we really need to rethink what we do. And if we measure what we do, call attention to what we really do and measure it, then the highlight will come on it and the professional identity will come out on it. One of our editorials called attention to a nurse who was working nights, worked her butt off all night long on a patient, on the family, really felt good when she was leading, but then she was called into, a supervisor office called attention to her documentation and the recent satisfaction surveys having to deal with something. And she just left morally defeated. Okay.
Yeah.
So, but wouldn't it have been nice if she was called in saying, hey, the HCAP question just came back and your caring was recognized. Families were calling attention to how you help them understand something, how you help them be successful in managing their own symptoms. I mean, we don't go there and we need to start going there.
Mhm.
And definitely, for example, I believe strongly that even if you look at DRG adjusted length of stays, there are certain lengths of stays on certain patient populations that could be sensitive to the work of nursing, but we don't take credit for any of that. Or readmissions. Surely not all readmissions have to do with how nurses taught patients to self-manage at home, but there are some that are sensitive. And if you talk to the nurses at the bedside, they will tell you what they do and what they don't do. And they know their patient population. You just have to ask them. And so we need to get to measurement that makes sense for nurses at the bedside. So lead a group of nursing on a particular unit. How do you impact patient outcomes? What outcomes are really important, in your patient population? And as, nurses who are expert at measurement, I'm sure you could figure out a way to measure it. And then, measure it locally and then, statewide and then nationally and start moving these metrics in. When we talked to CMS, and I said to CMS, and I said, have you ever looked at a nurse metric, that has anybody come to you with a nurse metric that might be important? They said, yes, once they came and it was like essentially a nurse burnout measure. Well, that's not a patient-centered metric. Nurse burnout is important, but it's not a patient-centered metric. When we align what we do to patients and families, we will strengthen ourselves. We need to measure all the other typical things like nurse turnover, how long it takes to orient somebody, nursing satisfaction. We need that. But in addition to that, we have to start paying attention to our impact on patient-family outcomes. Okay, when we align what we do to patient-family outcomes, the work becomes alive. Okay,
Yeah.
and it's what drives us. The patients and families that we care for. When we relieve their pain, when they're not nauseous anymore, when we put something into place that averted a catastrophe. Okay, when we advocated on their behalf, that's what makes us drive, what we do. Cardi and Clapsy, yeah, but it's a hell of a lot more than Cardi and Clapsy and pressure. So.
Well, and I'm just going to kind of, because we're getting towards the end of time, I do want to call out, and Laura Beth was wonderful in saying that the Midwest Nursing Research Society Conference in the spring, it's our 50th anniversary, and we have a symposium that's on this topic. We do have a link to the conference in the chat, and then Laura Beth also pulled out that we have some wonderful researchers in the Midwest who are going to share their current work on measuring. And again, I'll call out Dr. Norma Lang as the person who said that a long time ago. If you can't measure it, you can't evaluate it, and you can't make policy out of it. So I'll just say that we were all influenced by her. And again, it's really exciting that this is coming to fruition, because that would be definitely something that she would love to know that we're talking about at 8 o'clock in the morning with some wonderful nurses. And certainly I'll also give a shout out, Laura, Beth, and Martha. You have really inspired me with a lot of this, and hopefully we can pass this on, because I think this is a movement. I don't want you guys to be a rebel with a cause. I want to say that this is a movement. It's definitely long overdue, and certainly really something that needs to take shape. So I am just extremely excited about all the work. Now, again, Martha has done a great job on pointing out all the different ways that all of us can get involved. So certainly, I just think the fact that there's lots of opportunities is also exactly what we want to have happen. Do you want to bring us home? Laura, Beth, and Martha, give us some final words.
Well, I'm thinking at this point, again, all of us can make a difference. You know, we can't make a difference individually. It's really hard, but collectively, we can. And Mary, I appreciate your comments about going from the Fat 15 to the Rebels with a Cause to a movement. We need this movement. At this time in nursing, we need this movement. We need to pay attention to the work of nursing and what makes a difference to patients and families, and what drives us and why we entered nursing in the first place. You know, some of us have a lot of gray hair and we're going to be retiring, but we don't want to leave, you know, and retire until this work moves. And those of you who've got some longevity here, please pick up a piece of this and find yourself. And I challenge you to pick it up and move it forward, because it's going to take a lot of people to change. And the time is ready. You know, Magnet is rearticulating itself. The regulatory bodies are going through chaos right now. They're looking for some leadership here, and we can all make a contribution. Laura, Beth?
Yeah, I agree. I think as someone who works in a hospital with nurses at the bedside, helping them understand their full impact and their ability, their potential to help patients and families and make a difference is what's going to help with these problems that hospital systems are worried about: retention, burnout, turnover, those sorts of things. Making sure that nurses can fully appreciate their unique contribution. And so I love being able to be a part of this group and kind of move the profession forward in that way.
Mm-hmm. Thank you.
Well, this has been a really inspiring talk today, and certainly we're very excited about this work. Hopefully our rig will continue to spread the word and certainly help connect you with some really powerful people doing great work. So again, best wishes to both of you for your projects. I know that we've already connected with Dr. Carr, hoping to, you know, get maybe another spring webinar where he can share some of the findings with our group as well. So again, hoping that more and more of the people belonging to our rig will be behind you. So again, thank you all for getting up so early and joining us. And again, for MNRS members, this will be available in our MNRS webinar library, and please share it with your friends and colleagues. Thank you so much. We really appreciate it. Have a great rest of your day.
Thank you.